Welcome to our webinar on implementing the interconnected system framework, the role of school and community-based clinicians. Just double checking, Colin, you can hear me okay and we're good to go?
Yes, we're good to go.
Thank you so much. So this is Lucille Eber, and I'm the director of the Midwest PBIS Network, and along with Susan Barrett, Susan and I are members of the National PBIS team, and we're honored and thrilled to be working with the System of Care Technical Assistance Center, known as the Institute up here in the little chat box, in terms of sponsoring this series of webinars on integrating education and mental health, especially with a focus on system of care. We have a lot of names on the first slide here today, and you're not going to be hearing from everybody that's listed here, but all the people listed here were part of the planning in terms of this session today, and several will be presenting. And our agenda, of course, this is Lucille, and I'm doing the welcome and upcoming events. And then Mark Wiest will be talking a little bit about context and the challenge of clinician roles in an integrated model. And we're going to hear from Sharon Steven and Cindy Randolph about an example from the Northeast, and from Hearn about examples from the Midwest. And we'll move on to wrap up and next steps. We encourage you to use the chat room. Thank you, Michael Kelly, for telling me I sound great. I appreciate that feedback. So over here in the chat room, and we have plenty of team members here ready to chat with you and answer questions if things come up as we move along. And so our webinar series, in case you have missed the other two, there was one on March 30th and one on April 29th, and they're accessible through the Institute website, and they're also available for you at midwestpbis.org. And today, of course, June 2nd. Not sure how that happened so fast. I hope you're all experiencing some late spring weather wherever you are, and by the time we have our fourth in the series in August, you may be complaining about the heat instead of begging for it. And our August 11th will be around restorative practices integration. We also wanted to let you know about a project related to these webinars that we've discussed more in detail on the previous two webinars, where we are working through a targeted work group that's going to begin on June 30th. And the dates for the targeted work group are on the bottom. And some of you have already communicated with Susan Barrett about wanting to participate. Basically, we're looking for a small group of implementers from sites that want to serve as local demonstration sites and document their effort with some of our interconnected system framework tools, and so we can get some active learning. So those that want to get some technical assistance in a smaller group, specifically around planning tools for integrating for integrating mental health into the multi-tiered educational framework, please drop Susan or I an email and let us know, and we have a survey that we want you to fill out and then to join us on June 30th. To get us started for today, we had about 75 people register. There's about 35 that are actively on, with more coming on every second. But Colin, if you would set up this poll, basically we want to know who's with us today as we move forward. And so we have your options: community-based clinician, school-based clinician, community partner administrator, school-based administrator, regional or state rep, or other. We always try to get all the categories, but there's always people who don't feel that their other works here. So let's take a moment and see who we have on the call, and everybody can be looking at this as we go along. We're looking for 35 responses, and I think we're pretty close. I do believe other is our largest category at the moment, so maybe some of you could type into the chat room, those of you who are other, if you could let us know what your role is. We would appreciate that in terms of being able to know who's on the call with us here today, and maybe how we can direct some of our comments, because we do have the most people in the other category. But we do have some regional and state reps, and we have school-based administrators, community partners, and a couple of clinicians as well. So thank you for that poll, Colin. Let's go to the next poll on here. We have a second poll in terms of trying to figure out who's with us today. And this is just a quick yes or no. Have you participated in a previous Interconnected System Framework webinar or other presentation on ISF. So if you could, tell us yes or no. We have shared information about the Interconnected System Framework in previous webinars, and Mark, in his couple of minutes setup, will go through the core features again, but looks like most of you are familiar with our Interconnected System Framework model, and we do have a monograph available describing it. And but we do notice that some of you are not as familiar with it, and we will keep that in mind. I'm looking in the chat room at the moment at some of the other categories, and we have School Climate Transformation Grant project directors and district-based PBIS coaches and district administrators and mental health administrators. And of course, welcome to Nancy Lever, who's also worked with us, whose name was on the first slide in organizing this presentation. So thank you, Colin. Let's go ahead and switch over. Now is with us. And coming back to the PowerPoint here, hold on, I'll move this forward. I'd like to turn this over to Mark Weiss to talk to us about the context and the challenge for bringing clinicians together into an integrated model in school. They walk into a situation that isn't always perfectly set up for them. And Mark Weiss is the founding director and served as the director of the National Center for School Mental Health for at least 10 years. I might have that wrong, before Sharon Steven and Nancy Lever took over. And so I'd like to turn it over to Mark at this point. Mark?
Sounds good. So can you hear me now?
You sound great.
I'm assuming
you
the answer
sound
is
great.
yes. So I'm a clinical psychologist. I graduated in 1991, and soon after graduation took a job in the Baltimore schools. And what I'm going to talk about today reflects some of my own personal experiences in working in schools from the community mental health system, but also my experiences through the Center for School Mental Health, and since then in my work at the University of South Carolina. My whole career has really been based on this concept of enhanced quality of mental health services for children by having the mental health clinicians from the community system join with the schools. This helps the mental health system considerably by helping us gain access to children and youth in the most universal natural setting of schools, and helps the schools by bringing in additional resources to help with this work. About 7 years ago, Lucille and Susan Barrett began to recruit me more into the PBIS world, and I was thrilled to begin to make those connections. So together we've been working on the development of this Interconnected Systems Framework, or PBIS, and school mental health working together, not as two separate initiatives in schools, but as one initiative. And here are some of the key points that our PBIS teams include: the mental health providers. They're actually coming from the community and sitting on the teams and making decisions with and implementing programs and measuring programs with the community, with these school providers. That our decisions are based on data, and I've noticed in general the education system tends to use data better than those of us in the mental health world. We've got a structure for and formal processes for selecting and implementing appropriate evidence-based practices at each of the tiers, at Tier 1, 2, and 3. We're identifying youth that have needs with more formal measures, including screening measures, versus doing that much more informally, which is the common practice. We're really focused on, is what we're doing actually making a difference? Are we implementing programs as they should be implemented, and are those programs and services having the effects that we hope that they would have? And then we're actually not doing limited supervision, but we're coaching, we're working in teams, we're making sure that we're actually influencing systems and practices. However, the work is not easy. In the United States, I talk often, probably too often, about the challenges that we confront related to federalism or states' rights local control, so that you'll find this highly variable depending on where you live. So, for example, in a school district, the norm may be that in the district, let's say 100 schools, the majority of them do not have mental health providers from the mental health system working in them. And then you may have a couple where the schools, based on the initiative of the principal, has connected with a private provider, and then you may have a few where the mental health center has connected with some schools. But it's definitely ad hoc, and it's sort of all over the place. So a critical step is for that MOU development, that Memorandum of Understanding development, where there's one door through which the mental health systems joins with the schools to fill out what we're doing at tiers 1, 2, and 3 in improving our depth and quality of programs and services. Probably the number one, we've had a long-standing research program on quality in school mental health, and the number one, or one of the highest indicators in terms of importance, is the way that teams function. And I know that that's been a discussion in our past webinars. Teams often are challenged. They're not inclusive of the folks that should be on them. They're maybe not meeting at the level that they should be. They're not following up in the ways they should be. In general, the PBIS teams function much better than other teams in schools, but we see parallel play. In fact, we've done research in South Carolina where we find mental health providers in buildings where there are PBIS teams, but there are no connections being made between the providers and those teams. So how do we actually get the mental health providers sitting on the teams, assisting in problem-solving, decision-making, implementing evidence-based practices at all 3 tiers, not just at Tier 3 or for treatment services? And that's a challenge in that often mental health providers from the community system need to pay for themselves through
Mark,
treatment services. Yes.
you may want to pause for a minute. We have several attendees who are indicating that they have lost audio. Colin, can you help us?
Well said. So looks like we're good. Back to you, Mark.
Sure. So not sure where I cut out, but I was just reviewing the core features of the ISF, as you see here, and has been reviewed in past webinars, and then some of the challenges in actually implementing the ISF. Just briefly to review what I stated about this first slide, in many communities, the mental health system may not be involved in the schools at all, or is involved in a highly variable ad hoc manner. In a district, let's say, of 100 schools, maybe there are private providers in 2, maybe the mental health centers in 3 or 4, and then the rest don't have mental health center representation or mental health system representation. And it really calls for the importance of these memorandum of understanding to make sure you have a coherent agenda where the mental health staff enter through one door and follow common parameters, i.e. they do participate on the teams, i.e. they're not involved only at Tier 3, but at all the tiers, that we focus on some common evidence-based interventions, that we're using a common strategy for evaluation, et cetera. And the Baltimore experience, which I believe Sharon will talk about, is a great example of a systematic MOU that specifies all the parameters for the mental health system to work in the schools. An additional point I was making was that one of the most important quality indicators in the field is the functioning of teams, and often we know those teams don't function so well, with teams not meeting enough, not having great follow-through. Mental health staff from mental health systems usually don't participate on teams. They operate in a co-located manner in schools, and co-location is not really what we're striving for here. In fact, we've done a study in South Carolina where we have about 40 schools that had both PBIS and mental health staff, and we were sad to find that there was almost complete parallel play, that there was really no integration across those 2 initiatives in the buildings. Then in addition, all of this work, and we've used the term expanded school mental health on purpose to convey that as the mental health system comes into schools, that we're augmenting, we're adding to the great work that's already occurring in schools led by school employees, school psychologists, counselors, social workers. However, the national organizations will readily report that the ratios in buildings are usually far below what they should be. So we have far too few school psychologists, counselors, and social workers to meet the needs. And then that problem is exacerbated by, in some districts, where we have narrowing and constrained positions. For example, school psychology constrained into roles that are dominated by evaluation, school counseling constrained into roles dominated by academic advisement. These are important capacity issues for us to think about, that as the mental health clinicians come in from the community systems to join with the folks in the schools, that all of us should be engaged in all the work, and it shouldn't be that the community mental health clinicians get to do the preferred prevention and intervention work while the school employed staff are just as equipped to do that work. But this will require some systematic policy work in local districts to free people up to have expanded roles. We also see this notion of gatekeeping, where schools feel like they have just way too much need in relation to student emotional behavioral issues. And when students have more intensive services, those are more expensive. So schools may have procedures, rules, regulations that students, families need to get through in order to access mental health services. And sometimes those bureaucratic barriers can be fairly daunting for families. There has been some turf. It's to be expected. And for example, in the example that I just discussed with a community provider coming into the building and then being able to do things that the school employed providers want to do, that's not a good scenario. We certainly have to be attentive to that, and we have to be engaged in mutual outreach, so the community staff, as they come into the building, reaching out to the school employed providers, developing relationships, working to understand the other perspective, working collaboratively, engaging in groups together, doing outreach together, implementing prevention programs together, and moving beyond the turf. And we've certainly seen that when there's a purposeful effort to move beyond the turf, that schools and programs are very, very much able to do that. We also have to keep in mind that there's so much work to be done here. Here we are in this universal natural setting of schools with 20% or more of students struggling with emotional behavioral issues. We have to create the time to work together and coordinate our efforts, as in the ISF, than just all of us running around putting out fires and responding to crises in the moment in our extremely busy schedules. So anyway, that's my portion here. I'll stop, and at this point, I believe, turn it over to Sharon Steven.
And this is Lucille. Quick connector here. Reminder, some of the people in our second poll said they hadn't been to any presentations on ISF. So I just want to reiterate the main difference in having school mental health operate, as Mark says, in parallel play versus mental health providers coming in and being part of a system in schools, sitting on teams together and deciding together what interventions will be delivered, versus the mental health person from the community or other place coming in and saying, I'm here to deliver such and such service. So some of the important work up front that Sharon is going to talk about now, it needs to be done beyond the building level. We cannot just put the building level people together to work together. The leaders have to work together on policy and memorandums of understanding so that we can move forward. So I'm going to turn it over to Sharon Steven, and she has her partner, Cindy Randolph, with her as well. Sharon?
Great. Thank you so much, Lucille. Hi, everybody. This is Sharon Steven, and I co-direct the National Center for School Mental Health along with Nancy Lieber. It's quite appropriate that I'm talking immediately following Mark Weiss, who, as Lucille mentioned, served as our center's director for a number of years and was the founding director. And so much of what I learned and really the trajectory of my career has followed in the footsteps of Mark. So thank you, Mark, for providing that context. I'll be sharing information based not only on our experiences at the National Center, but also on our experiences actually serving as a community behavioral health provider at the University of Maryland for now just over 70 schools throughout the state of Maryland. So we have kind of that on-the-ground experience at the moment, as well as having to try to translate some of these efforts into best practice information and policies within our national center. And I'm also really pleased to be joined today by Cindy Randolph, who is the Behavioral Health Project Director for Connecticut's Safe Schools, Healthy Students Initiative, which is an initiative funded by SAMHSA, and it's a partnership between the behavioral health or mental health and education departments within the 7 states that were awarded, as well as with some of their other child serving systems, including juvenile services. And each of those states was awarded at the state level, but also have 3 communities within each of the states who are actually implementing the Safe Schools, Healthy Students model. And so after I provide a bit of context on activities for partnering with community-partnered school behavioral health providers, Cindy's just going to spend a couple of minutes talking about some of their process in terms of developing MOUs with community behavioral health partners and some of kind of what they're struggling with and some of their lessons learned from a real-world example. So I'm pleased to have Cindy join today. So before we actually get into the MOUs, we did just want to mention that there are certainly some startup steps for partnering with community behavioral health partners as a school consumer or a school partner of behavioral health services. And a few of those are listed here. I'm going to touch on them quickly, but one is conducting resource mapping and reviewing student mental health needs and findings. Another then is really defining between the school and community partner what mental health services need to be offered and how to manage referrals. And then finally, the step of developing an MOU between the school district and community mental or behavioral health agency. And these are not necessarily sequential. The MOU may be developed before doing some of this, but all of these are part of the process of partnering. And really, the reason we wanted to mention each of these steps is because ideally, both the school partners and community partners, as well as other stakeholders, including students and families, would be part of these startup steps. So with respect to resource mapping, certainly that can help us in identifying mental health programs and services both in the school and community, as well as those professionals who provide the services, with a broader intent of avoiding duplication of services and really enhancing communication between professionals both in the school and community. Of course, we would encourage resource mapping across the 3 tiers, not just necessarily for students with intensive mental health needs, but rather across the full continuum from universal to intensive. And really before beginning the mapping process, we would encourage all team members to take part in the discussion around the goals and roles in the mapping process, how will we map, and also then moving forward and identifying and mapping the actual resources and services in the school and community. For more information and kind of a process on doing this, I know that the National PBIS Center has some technical assistance tools to do this. We also have a resource mapping guide that we worked on as part of the ISF and part of the Maryland Safe and Supportive Schools Initiative in Maryland, and there's a link there. I can also put it in the text box so folks can click on that, but it's a resource mapping in schools and school districts. So there's a guide there, but that's one of the steps that we would encourage community and school partners to do together at the outset of this type of partnership. There's certainly a number of data sources that you can also use to actually then move on to identifying what are the behavioral health needs that should be attended to by both school and community partners. Some of them are listed here. This is certainly not comprehensive, and there may be reports and other data sources from your state or local health and education agencies. Again, the school and community partners are both critical to this process. The school behavioral health team may have access to data that can be helpful in identifying student needs, including school discipline data, truancy data, dropout rates, et cetera, whereas our community partners may be able to equip the school with some of their local community mental health agency data, what's going on in their broader catchment area, students who are presenting to the community mental health agency with specific diagnoses, for example, and the types of services being offered in the community. And too often, as Mark alluded to, these processes are really occurring in isolation from one another. So the community mental health partners might come in and not really have a great understanding of the school data. They may not be using, for example, dropout rates or attendance data or other academic indicators to help inform the services they might provide, and vice versa. The school folks may not be using the community data as well as they could to help inform the services that they're providing in the school. And sometimes it's, because they haven't put the necessary agreements in place. Sometimes it's just a lack of awareness for how they can actually use and connect to each other's data. Some of the next steps then are really having a dialogue between our school and community providers as to how are we going to actually plan for and implement services in a complementary rather than duplicative or competitive way. We've listed some of the questions that might occur in this conversation, but probably most relevant to this particular topic that we're discussing today are what are the specific roles of the school staff and what are the specific roles of the community mental health staff. And one of the challenges, again, that Mark spoke to is that there may be some overlap in both training and skill or competence of these sets of providers, and therefore it's really critical to have dialogue around who is going to be doing what and with which students and when in order to reduce duplication and redundancy of services. It's important then to have a conversation around specific logistics related to delivering services, and it's amazing how often we find that these conversations are not happening between community behavioral health providers and their respective schools. And so just some of these questions are critical to answer at the outset. What services will you offer and to whom? When will services be available? Who will provide services? Do the service providers need to be there on overlapping days, for example, so that community behavioral health and school-employed providers can actually have joint meetings to discuss the triaging process, to discuss data and how it will inform the students to be served and what interventions are needed? Do they need to spread their days apart so that there is 5 days of coverage by a mental health person, whether it's school or community employed? And there's not necessarily a prescriptive formula for doing this, but rather we just are encouraging as part of this ISF framework for community and school partners to have these conversations and to hammer out some of these logistics. Certainly identifying school schedule and optimal appointment times across school and community providers is critical. And I've already mentioned the days and times that community mental health staff will be present in the school, not only to communicate with school employees, but also to augment the services. And then some of what feels basic but can make or break community partnerships are things like office space, file cabinets, phone access for community behavioral health staff when they're working in schools. And then finally, the referral process, really discussing how will the referral process work, at which point will a student be referred to a community behavioral health partner as opposed to or in addition to a school provider, how will the consent processes match or complement each other, how will appointments be made. All of these are really critical in terms of figuring out, again, the complementary roles of school and community partners. I do want to make mention of the resource that will be available this summer on this topic out of our Center for School Mental Health. We've put together an 18-module free online course on community-partnered school behavioral health that goes into a number of these processes in more detail, and I'll put the link for MD Behavioral Health into the chat box so that folks can access that when it goes live this summer. But I now want to just turn it over, after I set the context, to what we've been doing in Connecticut. So again, I've been able to serve as the resource specialist to Connecticut for their Safe Schools, Healthy Students initiative. And one of the things that they've been working on is having the schools within their LEAs, the 3 local communities, having those schools develop MOUs with community-partnered school behavioral health. And as Cindy will be able to speak to, they've really had to contend with a number of considerations, including how to ensure that these community providers are actually providing needed services, how to avoid duplication of services, and then finally, how can they develop MOUs that actually capture and specify evidence-based services, that actually document fidelity, and that holds the providers accountable for the measurement of outcomes. So Cindy, I'm going to turn it over to you for a couple of minutes.
Okay, great. Thank you, Sharon. Can you hear me? I hope everybody can hear me. Many of the points that you and Mark have discussed, we are really finding as incredibly critical to the work that we're doing right now. I wanted to give an example. In one of our communities, the problem that we wanted to address was how to prevent out-of-district placements and how to help return kids who were in out-of-district placements back to the school district. So clearly we set up a plan of how to do this, and what we did is we brought together schools, districts, community members, and others together to really reflect on this issue. And our districts used the data that we collected during a period of a comprehensive needs assessment in which they found the data that would support what the community was really needing. And the clinician's role in this was very important. So it was really instrumental in helping us really figure out what the issues were and how we needed to resolve them. And our needs assessment was, based on all of that information. So we've learned many lessons, and the primary lesson I would say is really looking at how important contracts and MOUs are. And again, I agree with Mark and Sharon. And what I found is that we really need to empower ourselves as purchasers of behavioral health services for our schools and communities. And in order to do that, we need to use the data that is available and search for data that's not available to identify those needs and services. Because in doing that, we were able to determine what kinds of evidence-based practices we really needed in order to move forward. And once we had a clear understanding of our data, then we can look to our vendors, and again at the MOU or contract, and to set them up in a way so that they can be responsive to the community needs. And what we were looking at was trying to prevent out-of-district placements and return kids back from out-of-district placements. And what we found is that we really had to drill down to a much deeper level, the specifics of what we wanted from the vendors that we were looking for. And I think the big question is, what are we paying for? And I think that means salaries, that means what are the evidence-based practices, what are the frequency of contacts, of meetings, of interaction between school staff and vendors. How do we work together? And what we're finding is that it's really important to be able to articulate that in the contract. We are, I wouldn't say we're experts at it, but we're learning to be experts at trying to really write those things down and put that as part of the contract, describing the products, describing the services, describing the deliverables, and making sure that things that we want and need are justified. We want to look at the time frames. We want to look at the terms of payment. We also want to make sure that we include in our contract a termination clause. One of the things that we're going to be asking people is to provide a group of services. And so we need to measure that. And the way that we measure that, one of the ways we're going to measure it is based on what we've written down in our contracts. So the more specific the contract can be, the more helpful that will be. Sharon, I don't know if there's something else that you were thinking that might be helpful to add.
No, I think again, what you just explained is really consistent with our, what a lot of us have been aiming toward and struggling with. And, I think just figuring out how to write these things into our MOUs and to sit down as community partners in schools to determine what actually goes into the contract is really helpful. And I like the way that you actually contextualized it as assisting our schools and districts in being consumers of community behavioral health services instead of, just kind of having a partner come in and say, here's what we're delivering, but rather having them work together and having the schools actually be good consumers and ask the right questions. So thank you, Cindy.
Yeah. Thank you.
And so that's
it. Yep.
Yep.
Yeah. Okay, thanks, Sharon. Cindy, this is Lucille. I wanted to go back for a minute and reiterate some important points that Sharon and Cindy are making as we move forward to the next part of our webinar. And, when Sharon was bringing up the very important issue of, she calls it managing referrals, and I put that slide back up here. And then when Bonnie was talking about Cindy was talking about the importance of being really clear with the exact specifics of the provider. What I wanted to say was, if we're going to use a truly integrated framework, the community providers, or the school mental health providers, who are coming in from the outside, if you will, and then the school personnel that Mark referred to earlier, the psychologists and the social workers and the counselors, if they are considered as one system inside the building versus a system that is delivering off a contract that's a separate system, I think it will make a lot of the challenges that are being discussed a lot easier if people are working together through blended teams. But as Sharon and Cindy are pointing out, it all goes back to the leaders being clear up front what's expected. And if what's expected is that people will have dedicated time to sit on teams and do things such as resource mapping together. And Bonnie Evans in the chat room is pointing out the idea of, she really likes the idea of having resource mapping that does the school and community together to avoid the duplication of work. And that's what we are trying to promote through the interconnected system framework. And I appreciate Sharon and Cindy's example in terms of reiterating the importance of making decisions with stakeholders who have authority to allocate and commit resources, being the starting point for integration versus having the clinicians in the building working together to fill it out. So let's pause for a moment here, and we'll ask Colin to put up another poll. And as you can tell, the Center for School Mental Health, along with the Institute for the System of Care TA sites and the National PBIS Center, all have varieties of webinars and resources and things available. So we wanted to just take a moment and say, which of these areas on here would you want to learn more about? Is it about resource mapping, defining the services to be offered and how to manage the referrals, developing memorandums of agreement or memorandums of understanding? We're trying to just get some notion of the folks on this call in terms of what would be high priority areas for you for all of our collective centers who are working together to hopefully be able to address some needs in the future. And interesting, we're having over half the responses be about defining the mental health services to be offered and how to manage the referrals. And that's interesting because that is one of the major tenets of the interconnected system framework model, is that we sit together to do that, and we look at the data of the building and the data of the community, and the clinicians from various agencies along with the school folks together as one team build a continuum of interventions, and the referrals are actually managed through one team in the school. So the same team that manages the PBIS interventions is managing other types of interventions that come in through the addition of our mental health providers. So I can see that that's our highest area of need, and I think Susan and Mark and I and Sharon and everybody from the monograph end would say not surprising. So Colin, thank you for that. To the PowerPoint presentation. The next part of our presentation is we have Allie Hearn, who's a former school social worker, former PBIS coach, and now she works with our Midwest PBIS network and provides a lot of technical assistance and support to school district personnel who are redesigning the intervention systems in their buildings to ensure a more evidence-based approach for delivering services and helping people look at their data and using their data to define what interventions. And the other part of the work that Allie's doing in school districts across the country is helping clinicians, I guess we'll say, get comfortable with what perhaps might be some new roles related to progress monitoring and related to measuring fidelity of interventions and related to designing systems. Some of our clinicians come in through the schools or through school mental health providers or through agencies who have only been trained, taught, positioned, and told to deliver services. And when we build a more integrated model, the role of the clinician becomes a little bit more expansive inside a multi-tiered system in school. And Allie, along with Sherry Lupine, who's monitoring the chat room and responding along with others on our team, have done a significant amount of work with school providers in particular. And it's quite a struggle, as Mark pointed out, when school psychologists thought they were getting hired to test. Most school psychologists don't want to just test. They want to be involved in prevention, et cetera. But yet a lot of their experiences are just as siloed as Mark mentioned, that school mental health providers working in schools who come in from another agency, they're often siloed. Well, lo and behold, our school clinicians that were, born and raised inside the school system have also operated in silos. So with that, I'm going to turn it over to Allie Hearn, and she's going to walk us through the next part of our presentation. Allie?
Good afternoon. Thank you so much, Lucille. Can you hear me?
Yes, we hear you fine.
Perfect. Thank you so much. So this is such an exciting thing to be a part of, and this work is so exciting, and I'm glad to be here today to represent a perspective from having been in the schools as well as overseeing the process of installing a lot of this work into the school systems now and partnering with local agencies. So this is just really exciting. And in hearing Mark and Sharon and Cindy speak so far, it's really neat to see that we really do all have the same goals. And so hopefully we will be able to get there and accomplish everything that we all want to through this process. So thanks for being here and thanks for having me. Just a couple of statements on the upfront, a couple of big picture messages before I dig into a couple of examples from the Midwest. A part of what we know is that there's this increased focus on improving culture and climate in our schools. And there's messages coming out of the Department of Ed around this, and all you have to do is turn on your TVs to know the importance of trying to be a part of the movement towards improving culture and climate in our schools. Social emotional learning is moving from being a consideration in the schools in terms of, hey, this is something we should think about, to being more of an expectation and in some places even a mandate. And so we know that finding a way to put social emotional learning into the schools is so important. The problem is that we're starting to make this be an expectation that all people in the schools help support social emotional needs, which is incredibly exciting, not just clinicians, but teachers and aides and everyone throughout the building. But there isn't always a description or clarity on how exactly to go about doing that. So it's an everyone concern, and it's something we want everyone to be a part of, but there isn't always the how on how we should go about doing this. I love this quote, too, from the Vice President of CASEL, who says, we sometimes receive pushback from teachers who say that right now my top priority is Common Core. So we're asking folks in schools to do more and more and put more on their plates, and yet we're not always giving clear messages about how exactly to do that. And so we, those of us on this call and those of us who've been doing the work, know that the partnership between clinicians in schools and clinicians in the community can help so much with alleviating the long-term work, but a lot of folks need help in terms of seeing how we're going to get there. So I like to talk about the old system and the new system. There's sort of this old way that we did things in schools and how we partnered, and then there's this new system. And I'm so excited to be a part of this work because of the new system. But I'm going to talk for a couple of quick minutes a little bit about the old system, and this is sort of that pre-MTSS, pre-ISF integrating kind of a time that we're talking about. So I call this like the magic wand approach. Anybody who's been inside of a school, who's worked in the schools, clinicians from community and from in schools who've done this work, there's sort of this mentality that clinicians have this magic wand. Like you send a student with any concern at any time to the clinician and it's just going to poof be fixed. And from having been a school social worker and an LCSW and having done this work for a while now, that's very flattering and that's very nice of people to think that. And at the same time, it's not systemic, it's not systematic, and it doesn't help all of our kids. And so I've heard on this call from a couple different people saying that we need to come up with better ways of deciding who gets what and how we can do that in a systematic way so that all kids can get the support that they need at the levels that they need it. So this is for school and community-based clinicians. How is it that we're deciding which students get what? How are we making those decisions? And the old way of doing things was pretty subjective. So you'd have people saying, I think we should do this. I feel like we should do this. You know, Johnny's brother received this, so maybe that would help him if we gave it to him. At times it's been washy, and that's not as effective of a practice as we could have if we tried to approach this in a different way, which is what we're starting to do. So the data-driven approach is going to help us so much in really figuring out which kids are going to receive what services. And in terms of taking a look at how students are taking the skills that they're learning and generalizing them to the rest of the setting, we typically have just asked clinicians, what do you think? How are they doing? And again, that approach isn't going to get us the outcomes that we're looking for long-term, the supports to all the kids that we need and the strong partnerships that we're looking for by just using subjective measures. And so we really want to be finding ways to use data that's going to help us see if our youth are improving, you know, across all settings, which is what we want. And, you know, the last point here is just that a clinician has often been asked to cover multiple jobs, and that's definitely the clinicians in the schools, but honestly, that's even clinicians who come in from partnering agencies. We kind of sometimes ask folks to juggle a lot of balls or even to do things that aren't necessarily a part of their job description. And what that's done is it's really blurred the lines of who's doing what, and it's made us misuse our clinicians at times and not be very clear about how we're using them. So you'll hear me talk a little bit more about wanting transparency and clarity around what it is that our clinicians are doing for the benefit of everyone, so we're on the same page. We've sort of been a part of this epidemic of over-servicing students with low-level needs and under-servicing students with high-level needs in the schools. And this has no boundaries. This isn't just Illinois and this isn't just Midwest, but we see this across the country, that we have systems set up that allow us to over-service students that have low-level needs. And so a student might be flagged for having a need or show up at the clinician's doorstep and are, you know, they're presenting their need in a very intense way. And so very quickly, this student will start to get clinical services, and you may even find out that they land themselves being a part of the IEP system and having an individualized education plan that is going to now travel with them for a very long time. It's often hard to get kids out of that system. And so you might have students with lower level needs being over-serviced in that way, and then some students with high level needs who maybe don't present those needs in such a way like that. Maybe they're students who have internalizing characteristics, and so they kind of fly under the radar. Those students end up getting underserviced in the schools. And so we really see this pattern over and over, that there's not the right level of services being given to the appropriate level of needs. And our goal here really in the schools is to match the perfect level of support with the perfect level of need. And so I think it's exciting to continue to see us having this dialogue and partnering with schools and communities to make sure that this happens. We don't want it to just be that the squeaky wheel gets to have the services. So we always want to be considering how our time is being spent. And this is just a graphic that has helped in this dialogue before to sort of talk about that. Does the intensity of the need match the level of support and the time that's being provided? And so from these triangles, just in terms of time spent, you can see that on the left, it's very large on the bottom. There's all this time that's being spent, but it's with tier 1 level needs. And if you look at the second triangle, you see that there's much more time that's being allocated or available for students with tier 3 level needs. And so, you know, in talking with clinicians, we will often ask, where do you fit? How do you see it in your school right now? Is it upside down? Is it right side up? What's really happening? But the bottom line is that we want the right level of needs being met with the appropriate level of supports and services. And the truth is that right now lots of schools are upside down, And again, the way that they're deciding kind of which students get what supports is kind of haphazard or subjective, and it's not very clear. So we use this slide and this model to start to talk about what it could look like for clinicians in the schools. And there hasn't been a lot of direction about that as you talk with people across the country for what exactly it should look like. And this is a model that starts to really help us put some structure and framework around this. I love how Mark said that there's a lot of parallel play going on, and that's for sure the case of what we see in schools. So we want it to be really transparent who's doing what, and we want to start to put some framework and help support the direction of where the clinicians are going, whether they are school-based clinicians or community partners who are partnering together with the schools. So we want to be more clear on what the clinicians are doing and what it is that we want their role to be. And you see on the slide that there's coaching in each one of the 3 tiers. So what you're going to hear me talk about next is that we kind of want to be shifting our clinicians from solely being the people who provide the services and the school seeing them as that like magic wand, to starting to put them in a position of leadership and having them oversee interventions and oversee training and passing off some skills to others, and really building the capacity of the building through coaching and teaching and training. And so I'm going to get into a little bit more detail about each of these different levels, but we basically talk about consultation being at that tier 1 level, so it's not as intense, just like the needs aren't as intense. At tier 2, we start to talk about coordination, overseeing interventions, helping organize, helping those systems pieces. And then tier 3 is where you really see that facilitation coming into play, where there's direct services being given, one-on-one, adult to student, that kind of thing. And unfortunately, up until now, that facilitation piece is really the only piece, for the most part, in lots of places that has been in place. So there's been a lot of direct facilitation, but not as much overseeing of coordination or leadership in terms of like passing off skills. So just a quick piece here about the language and the verbiage of what I'm using in terms of talking about a coordinator versus a facilitator. I'm not as concerned about what language you use as I am that we're all talking about the same thing in terms of function. So what I'm talking about when I say coordinator is someone who oversees, organizes, is the coach or the person, the champion, overseeing the processes and the data and systems, so to speak, of that intervention. And it says on here, you can see that their roles might include scheduling or collecting data, those types of things. In terms of the facilitator, we're talking about the person who's actually delivering the service. So that's the big difference here. One person might be overseeing and one person might be delivering. Sometimes these people are the same person and sometimes they're 2 different people. But it's really important that when we're talking with our clinicians and when we're talking to folks in the schools, that they understand that there is a difference between these 2 roles. So the coordinator is not the same thing as the facilitator, and that's something that's sort of gotten confused or blurred, I would say, in the past. To dive a little bit more into each of these tiers, of course, we don't have a lot of time today. This is something I could, talk for a whole day or more on, and we have, and it's really fun and exciting to do. But in a short amount of time, just a quick couple of points here. When we're talking about the tier 1 level for a clinician in the building, be it the school-based clinician or a partnering clinician from the community who's coming in, we're thinking of this more in terms of consultation. The coaching, of course, but really in terms of a consultative mode. So we know that to consult is to seek information and expertise from somebody else, and that's really what we would want the clinician to be doing at this tier. Because the needs are lower level in the tier 1 level, we wouldn't want the clinician to get too deeply embedded here because we want to be saving their expertise and their time and really the bulk of how we're using them to be higher up in the triangle where the needs are showing themselves to be more intense. So they would be doing consultation. These are just some examples, but they might be doing consultation with teams in the building, like a universal team or a secondary team. They might be doing consultation with entire systems. So the discipline system, for example, in talking about how do we keep kids from not getting sent out of the building so that we can provide their services in the building. They might do consultation with the deans or the administrative teams to talk about discipline. They might be doing consultation with all staff, doing delivery of content at all staff meetings or things like that. There's a lot of different examples that we can give, but we're really wanting to try to start focusing more on keeping it more less intense with the way the services are being delivered at this tier because the needs are less intense at this point. I like how Mark had said that we see a lot of teams not functioning very well in the schools, and as a school-based provider before I came into the PBIS world, so to speak, I can't support that notion any more than how you said it, that our teams are really not working as well as they can in the schools. So to be a consultant to a team, that's a great thing that a clinician could do. They're going to ultimately end up helping more youth if we can get their role at the Tier 1 and Tier 2 levels to be pretty effective and pretty efficient with the use of their time. Sometimes we have clinicians that just get too bogged down at that Tier 1 level, and too much of their time gets spent there where it should be being placed with kids that have higher level needs. The Tier 2 level, we're talking about coordination. And so this is, Tier 2 is where you're going to see the biggest shifts in building capacity that would be taking place, I would say, in a school building. Because if you can shift what's happening at Tier 2, it's going to allow you to pass off some of the skills of the clinician, have some other educational professionals in the building start to do some of the tasks that might have been done by a clinician before, and you'll ultimately get to help more youth with less resources or time spent from the clinician. So here they might be overseeing training of others. A clinician might be overseeing an intervention, helping make sure that it's running smoothly. They won't necessarily be delivering all of the services themselves at this tier, and that's probably the biggest shift for our school-based folks to understand. So even a partnering community clinician coming in might think that they're going to come in initially and do, mentoring, and that would be great, take on a mentoring position, but they also might sit on a Tier 2 team or start to oversee a Tier 2 intervention and shift into more of that leadership role to ultimately be able to help support more youth. It's pretty exciting time to start to see some of those changes taking place. And then at the Tier 3 level, this is some of the work that we're more accustomed to, that direct individual support that clinicians often do with students. So we're definitely not taking this piece away. Sometimes folks in the schools get very scared when they hear that we're shifting these roles a little bit to build the capacity of the building to help support all students' social emotional needs. They might ask questions like, what does that mean for my job? Will I still have a job? And we're very proud and excited to say, yes, you will. There's a lot of work to be done, and a lot, the students were wanting to still support all of the students. It's just shifting the role a little bit. So again, with Tier 3, we want to be keeping the clinician services and supports at this tier if at all possible, because this is where the real heavy lifting comes into play in terms of the needs, and that's where we need our best resources in terms of background with behavioral expertise to really come into play if at all possible. So we sometimes wonder, where do school and community-based clinicians fit in, and how would they move through a triangle? And so it's sort of this build-as-you-go concept. So it's not surprising for a building who's starting out at the Tier 1 level to have a clinician, be it school-based clinician or community-based clinician, come in and sit on their universal team while they're developing their universal data practices, all that stuff that's going on there, and while the systems are really being developed. So you might at first start out on a universal team, and then as the system moves and as the layers are being built and the deep continuum hopefully is being built at Tier 2, that clinician might travel up to the Tier 2 level, start to be a Tier 2 coach, start to coordinate and oversee some Tier 2 interventions. And then as you build into Tier 3, they might move on to become that coach at Tier 3, do some Tier 3 facilitation. There's different ways that this can look, but this kind of starts to give a sense for how a clinician can help build the system and move through it as they're doing that. Of course, helping build capacity and teaching others and doing trainings with others as they move through. So really, we are talking about moving from being the only response to identified social emotional needs to being more of a social emotional leader in the building to really help build the capacity of the rest of the staff. We can't any longer have the days where if the clinician is out of the building, the whole building feels like they just can't make it. We need to feel comfortable knowing that in our schools, everybody, all of the adults are there to help support the social emotional needs of the youth, and we want them to feel comfortable in doing so. We're not looking for every adult in the building to be doing trauma-informed care. That's not what we're talking about, but we need everybody to have a basic understanding and knowledge of how to get supports to kids when they need it, and really to know that it's not a haphazard thing that a squeaky wheel is just going to get some support, but that there's really a process to it, and there's data-driven decision-making that's used. So a lot of clinicians are starting to get excited about this leadership role and starting to see it in a little bit of a different way for how they can be involved in the schools. So anybody who says, I fear that there won't be anything for me to do, or what is this going to look like in the future, I've sort of broken this down into these 9 areas of ways that you can think about this in terms of the domains of homeschool and community. and then the tiers, tier 1, tier 2, and tier 3. And there really is work for a clinician to do in all of these different pockets. And we could do a whole nother webinar at some point probably to talk about what all those different roles and activities could look like. But this really helps our clinicians in the schools and in our partnering agencies to be thinking about, if we try to cover all of these entities, how can we put supports in place at tier 3 in the community? How can we put supports in place at tier 2 for home? And that doesn't mean that we're going to go into the homes and try to force supports into homes, of course, but how can we do a better job of engaging our families and help offer ideas about supports and even offer things within the schools and partnering with our communities that would help our parents and families to support our youth. So these are some of the trends that we're starting to see in the schools, and it's an exciting thing to know that this shift is really happening. I've been incredibly honored to be a part of all this work as the shift is happening, because it's really empowering and it's been really exciting for our clinicians. So we really are moving from reactive to preventative. That's an exciting thing. We've been very reactive over the years in our schools. We're moving to try to be more time efficient and, as was mentioned earlier, to be as least restrictive as possible. I think Cindy was talking about that. It's really neat to know that we're on the same page and that we have those same goals. We're moving from tier 1, doing heavy. There has been a lot of heavy facilitation and coordination at tier 1 just because that's where clinicians have gotten stuck in the past, and so we really are moving towards leading and overseeing at tier 2 and tier 3, and definitely still facilitating tier 3 interventions where you have individualized student teams coming into play and you have individualized services needing to be delivered for individual students. But when you get caught up doing these individual student plans and heavy clinician resources for kids who have low tier 1 level needs, that's a real miss in the system, and we end up abusing our services. And I can say even from the schools, when I would see an outside clinician come in, which has this wealth of knowledge and amazing resources for our kids, and it was being used on a student with lower level needs, let's say, than the ability of the provider coming in, it would just be a miss in the building, and we could help support so many more students if we reshuffled that. So it's exciting to see that happening. We're servicing students in a more purposeful and intentional way. It used to be that we just service students based off of labels that they had. If a student had certain IEP label, they would just get services because, and now we're really being more purposeful about that. We're using data and making sure that we're not over-servicing kids, which is a very good thing. And we're really looking at reaction to life circumstance and not just assuming because a student comes in with a life circumstance, be it a death in the family or a divorce, we're not making assumptions about what kind of supports they need, but we're really looking at their reaction to those events in order to see what kinds of supports we can put in place. There's a systems approach that we're starting to take on, looking at the buildings as clients and not just going one kid at a time, but actually thinking for this entire building, do we need to put in some trauma-informed care here? Or for this entire building, are there some issues of poverty that we need to address as an entire school? And so we're really just looking at things from a systems approach as well. We're trying interventions first, and we're not just referring directly to a professional. So we're not just having kids go right to a clinician, and we're not just having kids land right in an IEP. And so you're starting to hear in the school buildings the question being asked, when they talk about, this is school lingo, but when they talk about opening a domain to do an IEP, rather than someone just saying, sure, I'm going to do an entire social developmental history on the student, you're starting to hear people say, have you tried putting them into the MTSS, looking at some response to intervention? Have we done PBIS efforts yet? And that's a really exciting conversation to be hearing taking place. So with a very shortened version of some big picture messages about the shifts that are taking place in schools and in our partnerships with the community, how easy would you think it would be to engage others in this kind of dialogue? For some folks, they've already been having this conversation, or it would be pretty easy to start talking about the shift. And for others, it's kind of a challenging conversation, and it can be exciting, and it's also, it can be hard. So just a quick poll here to ask you, how easy do you think it would be to engage others, either in your setting or if your community to talk to the schools, if your schools to talk to the community? Let's just take a poll real quick to hear our thoughts.
Colin, can we put this poll up for the participants, please? There we go. Give Allie a minute to take a breath while you complete the poll. Most of the people on our webinar today, if I read the polls earlier correctly, do not work in school, or you don't have their primary role as a school-placed person, although we have some. And, you know, Allie's presentation that Sherry Luking and she do a lot of this work together, and she'll continue in a moment, is done just with the school people a lot of times. Now we bring in the clinicians into our ISF model and it becomes a broader conversation. So I think the results of the poll, Allie, are showing that people recognize the challenge. I can see that right here. We don't have too many people saying that this would be easy. We're more in the moderately challenged role. So
Yeah.
Thank you, Colin.
Yeah, so I think that that's exciting to see. There was, this is just how I am, but there was nobody who said it'd be easy. So the good news is we're all in the same boat together, right, that this is challenging conversation to have. And most people said it'd be moderately challenging. And that is the case of what we're seeing when we get the community partners together and the schools together and people who are not clinical based, like when we have teachers and other, you know, administrators, other folks sitting at the table. This is some new and interesting and different kind of dialogue. And for me, that's what I love the most. I think it's really exciting to push the system and to try to help our kids even more than we have in the past. So it is a good thing. It's an exciting thing. And I'm going to move now into some examples. I wanted to put up an example of some guiding questions. There's 2 different slides that you're going to see. And these are questions that I've actually used personally when working with administrators and clinicians to try to create some dialogue. Sometimes I've done these questions just with clinicians to get them talking, and sometimes it's been a combination of clinicians with administrators. But these are 3 of the big questions we talked about, and something interesting for you all to think about, for you maybe to bring back to your settings. The first thing is, how would your administrators, your staff, the other clinicians in your district or building or setting, how would they describe the role of the clinician? And when I've done this activity, it's been just mind-blowing to see. You could just watch the eyes in the room have these aha moments, because either A, it's challenging for them to describe the roles, or B, they realize, oh my gosh, our staff will describe this so much different than our administrators, or our clinicians will describe this so much different than our staff, you know. So starting to really have more transparency here and more clarity about what is it that everybody does, especially if you're in a district where there's social workers and psychologists and school counselors. People are not always familiar with the systems and how it works and who does what. So bringing more clarity to that is going to help with everything, but it will definitely help with our systems and helping make sure kids get the right level of support. The second thing is, how are decisions made about when to give youth more social emotional support? And this really sheds light on the fact that we're not always using data-driven decision-making. So when we're using other haphazard means or just kind of, you know, throwing a dart at the wall, so to speak, about who should get what, it's kind of again, an aha moment for people in administrative positions or people who are decision makers to realize, how intentional have we been, or how unintentional have we been? And just that knowledge right there can start to shift the systems. And the last thing is about how are clinicians able to report on whether or not the work they're doing with students is effective. And this is really important for our clinicians in partnering agencies as well as our clinicians in the schools. How are we taking a look at, are the kids responding to what we're doing, and is what we're doing working? So this kind of puts the heat on everybody, because we're not only asking you to take a hard look and say, are kids responding to what you're doing with them? But we're also asking you to take a look at, are you doing what you are coming in to do, or you're in the building to do, with fidelity, and is it even getting, you know, is it getting the outcomes? Is it being done correctly? Is it evidence-based? So it's some tough questions for a lot of people to ask. And there's not always data collected on it. So I can give an example just from a school. When we used to bring students to a therapeutic setting to go to a farm, and there were some interventions there, I'm not sure that there was data being taken on how the students were responding to that setting. It was just something that was good to do, and so it was something that we did. And that's just a brief example, but that's happening all across the country, that we're just giving services, and the challenge is, if we're not getting response from kids, or if the services aren't being done with fidelity, then we may not be getting the outcomes we're looking for, and we might not even know why. So these are some great questions to be considering as you start to have some of these tough conversations too. Here again is some guiding questions. The slide I just had was kind of some conversations between clinicians and administrators, and this one has been geared more towards clinicians specifically, but really digging into considering the role of coordinator versus facilitator and who's doing what. And these are just examples from a list that we have of longer ones, but the last example on here about considering the capacity of the staff in your buildings, this is a big one, because clinicians start to say, hey, if I'm not going to deliver an intervention at Tier 2, who is it that's going to deliver it? And so that conversation about who else can we include in the building is usually it's an important one, and it can be a challenging one. It stimulates some healthy and challenging dialogue. So when we start to think, hey, a social worker in a building could co-facilitate a group with a librarian and then pass that role off to the librarian to lead a skill development group, that is in the realm of possibility. And so it starts to really open folks' eyes to what can be done here. Again, we never want to guide people into thinking you're going to do some heavy trauma-informed group and have a librarian leading it, per se. But if there are things that others can do in the building that don't necessitate the highest level of behavioral expertise that we have, we want to consider doing that. And I'll talk a little bit more about that. So I'm going to give you two specific examples, one from Illinois and one from the Midwest. And these are two districts that have been doing some work here in terms of integrating community partners into their districts, and they also have done some really good work in terms of shifting the roles of their clinicians in their district. This first example is a district who's been at this for a while now, so they're doing a really good job, and you'll see here on the slide some great examples. The second example is about a district who's just getting started, and we can take a look at some of the initial steps as they dig into this work. So this is a district in Illinois. They have 53 school buildings, which is quite large for us here in Illinois. They have community partners sitting on Tier 1 and Tier 2 teams as active members. It's really exciting. They are partnered with 20 community partners. That's just a list of a couple of the partners that they're working with. They have 57 providers who have been trained. It's really neat to do a training in this district or be a part of a training, because you'll be sitting at a table with school-based folks and community-based folks at the same table. And so the dialogue that takes place is very exciting. They regularly attend PBIS trainings, and they also will regularly attend, if they're on teams, those team meetings. And having their voice at the table is critical. I remember being blown away at a training when the community providers were talking about how badly they want to get in the schools, and the schools were talking about how badly they want the community partners to be in. And I was thinking, like, why is this not more, why is this not easier to do, and why haven't we done it sooner? So it is exciting to see that we're all having the same conversation, and there are places who are starting to do this. It's really neat when you see the community partners facilitating interventions, and it's also neat to see them overseeing or being leaders of interventions, and you might even see them co-facilitating interventions while they work together to deliver to students and help build up everybody's skills. They are doing other ISF core features like universal screening and progress monitoring, so it's just been really nice to see the outcomes here. And they do have a community alliance, which has really taken shape nicely over the last years, and they meet about quarterly, and they action plan and move forward as a truly braided joint team that's now just one team, like Lucille had talked about. And so to have that approach is really exciting. This is an example from out here in the Midwest, and it's actually another bigger district, 56 school buildings in this district. And I had the fortunate opportunity to get to go to this district and help them as they've started from square one to really lay the groundwork and do some readiness for ISF work, and really start to think deeply about how they're going to shift the roles in their districts for clinicians who are in the district and for the clinicians that they're partnering with. They have 125 clinicians in their district, and we got them, or plus, they had some over that, but we got them all in the same room, and it was the first time in the history of their district that they were hearing the same messages at the same time, collaborating with one another. I would say I learned just as much that day as I hope that they did. It was incredibly powerful. It was amazing to hear the dialogue between groups that they didn't know what their partners were doing across town, or even sometimes in the same building. It's amazing to see when you don't know what's going on, and that's that parallel play again that we were talking about. So they have social workers, psychologists, school counselors, and psychotherapists from the community that are all working in the district. And the goal for the PD at the beginning was to have consistent and clear understandings of what MCSS is. So really making sure that everyone understood a multi-tiered approach to helping support behavior for youth. We wanted to do a little bit of analysis about where we are, so they were taking a look at what are they currently doing, and then started to envision what could be. And then the increased collaboration was actually a huge goal of theirs, because they have just never had this opportunity to all talk together. So we scheduled 3 different events where we were getting them all together to have this conversation. The first 2 sessions were just with clinicians, and we were just getting everybody on the same page. Anytime you get over 125 clinicians in the same room, it's going to be a good time. So we had a really good time all together. A lot of learning was had, fears were able to be put on the table, and a lot of validation just about where this work is going and how it might feel. So that's been a neat thing to do in districts like this. The last session included administrators, and that's something that was incredibly powerful. We got administrators and clinicians engaged in these conversations about data systems and practices, and that's where a lot of the aha moments came from a systems perspective. The district is moving forward with 6 exemplar sites that they have identified where they really want to push forward and shift their systems effectively and efficiently so that they can create the outcomes for youth that we're all looking for. Their next step is that they are going to start to learn the process of FBA and BIP, so behavior intervention planning, and they're doing it within the PBIS framework. A real interesting dialogue came up here because this notion got brought up of who should get to house this knowledge, and I think that this one specific example speaks volumes about kind of what we're all talking about, you know, with who comes in with the expertise, and do we want to spread that wealth of knowledge and build that capacity for others to be able to do that? Is that a good thing? Is that a threatening thing? What do you do with that? And this district really dug deep into that notion. So where they landed was that everyone's going to get that knowledge and that education and be able to deliver those services. And the psychologists are going to be the leadership group who are going to do more of the coaching and overseeing that intervention and helping really bring up the skills. So I think this conversation continues to happen. This is, like I said, one small example, but with our clinicians out in the community who are coming in and partnering with us and the clinicians in the building, who's going to do what? And how do we do that without it threatening their role, but instead with it helping them to become a leader to build up the capacity of the whole building or the district in this case. And so they're going to just continue with this education on how to help their clinicians be social emotional leaders. And that language is a big shift, like I've said, in the building. So if we can help to continue to have the staff see all of our clinicians as social emotional leaders, that will change the way that they're trying to get kids services in the building. So the district's plan, it's just been really neat to see them talk about this in terms of considering data systems and practices from the get-go. They are considering bringing community partners in and how they're doing that. They already have some, but I would say it's not as fully integrated as the first example that I gave. But the crosstalk between the clinical departments is really exciting. Having this paradigm shift conversation at the district level is very exciting. Figuring out where everyone is going to fit into this puzzle and how to do it in an effective and efficient way is just, it's exciting, and it's definitely a powerful conversation. And the data in terms of monitoring the outcomes, you know, again, that's conversation that needs to be had in the buildings, in the district, and with community agency partners and providers, because everyone needs to be thinking in terms of how are we going to use data to make the decisions about who gets what. So they're really laying a strong foundation for this ISF work as they move forward and continuing to really bring in and embed and partner with the community agencies. And I know it's challenging to discuss and have dialogue around once we shift these roles and kind of change a little bit about maybe the way some clinicians have worked in the past, who's left or who's going to come in to help support. And it's really an all-hands-on-deck approach, I think. So we're really looking for everybody to feel more comfortable in the schools, being able to have dialogue around this important work. So that's a little bit about what we've done in the Midwest. And just
thank you, Allie. Thank you, Allie. I'm going to leave this slide up here for a minute. Allie's discussion came with examples of clinicians playing a greater role than just the delivery of services. I noticed there was the all-important, most frequently asked question. Thank you, Sean, for asking that question about how do you pay for this. You all come from different states and different places. So, for example, in Pennsylvania, where Kelly Paralis has been working, there's managed care systems. And in the MOUs that Cindy was talking about earlier, it may need to be spelled out. If there's going to be any payment for any services between agencies, it should be pretty clear that systems work and data work is as important as the practices work. We do have a history of systems of mental health where all we do is pay for clinicians to, quote, see kids and deliver services. And we have strong reason to believe that the lack of system foundations and teams to problem solve situations and the lack of using data probably contributes to the outcomes. The other issue is investing time in systems development does what Allie repeated many times, is that we have underserved kids. On the other hand, we've seen a lot of federal grants and other projects where the outcome measure is simply how many kids get services. And we know that comes from a good place. People are concerned about underserved populations. But we feel the measuring of the fidelity of the intervention and the measuring at regular intervals, whether the intervention's having the intended impact, and if not, change it, is just as important as more kids accessing more services. So we do have a lot of challenges in front of us. Sharon put up some webinars about funding. We've had other other resources about funding. We have definitely had other webinars that in the ISF series last year that are available that talked about funding, and Sharon's putting some resources there. But the bottom line, as Kelly says, is we need to remove that barrier of billable hour and have our leadership people at the systems level who are creating funding streams and creating contracts. I love how Cindy said we need to know what we're paying for. Well, we want to pay for system participation and use of data as well as the practices to ensure that things are going to be effective. And just as a way to make sure you're all alive out there and still on board with us in these closing moments, we have a final poll. Which area do you think needs the most attention and consideration when looking at the role of school community-based clinicians? Is it their role with data, their role with systems, or their role with practices? And, you know, I'm looking quickly, and, you know, we would concur that the systems piece is what's not getting the attention. And so we have a lot of progressive thinkers with us on this webinar today, recognizing that we have to build solid systems. And we have to get past the bring in the clinician just to see the child and then exit the system. So we really appreciate the fact, number one, that you let us know that you're still out there and still listening with us and still thinking about these issues. But yes, it is the system features that are most challenging. Thank you, Colin. Can you? We wanted to remind you of a couple of upcoming events. One is our August 11th, is the fourth in this series that started in January through the Institute. And we're going to talk about another challenging topic that of great interest to people working in interagency initiatives and system of care, and especially with the juvenile justice is where this came from, but the integration of restorative practices into schools, which is a hot topic. There's not a lot of solid research on this at all, so we're all moving in a very careful manner. And as I mentioned earlier, we're starting the ISF System of Care targeted work group. We're looking for a small number of sites with a small group of leaders per site who are willing to join Susan Barrett and our other colleagues and I in a technical assistance approach of using some of the ISF tools where we can actually walk a couple of sites through the use of the tools to set up their integrated systems, and that way we can all learn from each other. And in case you don't want to go back and look at the other webinars for the goals of the work group, and I have Susan's email up here. She's handling the requests, and if you let her know you're interested, she'll send you a link to a survey that we want you to complete as we plan for the June 30th with the first of our targeted work group series. We also have two upcoming national events that involve ISF strands at the conferences, and one is the U.S. Department of Education's National PBIS Leadership Forum in October on the 22nd and 23rd, with mental health integration being a strong topic there, and then the Center for School Mental Health Conference the next month in November in the great city of New Orleans. So those are two places that you might get other resources. So we want to thank everybody for joining us today, and mostly I would like to also thank our presenters, starting with Mark Wiest and going with Sharon Stevens and Cindy Randolph, did a wonderful job talking about some of those hard policy issues. And Allie Hearn, who spoke for she and Sherry Luking, who often do these together, sharing our experiences working firsthand in some of our school districts that are struggling with the changing role of the clinician. And one of Allie's example, our Illinois example, was a district that has reached out and brought the community providers into the buildings, and we've presented on that district before. Another district, a district from Nebraska actually, has a lot of community providers operating still in silos, but the first challenge in that district is getting the school clinicians not to operate in silos as we're getting ready to build the ISF structure in that district. So we hope those on-the-ground examples were helpful to you. I see there's still dialogue going on in the chat room. Really appreciate, Michael Kelly, your comments about higher ed. And Michael, if you've been following the chat room, was I guess we'll say lamenting somewhat that sometimes even our training programs are not focusing on the multi-tiered system role of school social workers. And Michael also referred to and shared a link to a survey that was done on the role of school social workers that's published in the online Springer Journal. So Michael, thank you for that. And I think the combination of different dialogue here in the chat room has informed us all, and we look forward to having some of you join us in our next webinar. Feel free to email any of us along the way with any thoughts. All of our emails are in the first slide. And thanks to Colin and the Institute, and we will send out an email to everybody who is on here with the recording and all the information. So thanks everyone, and have a great spring afternoon,